Hello, welcome back everybody. We're going to move on now to the next few speakers. First up, we've got Dr. Alexander Manu, who is going to be talking to us in just a moment. Alex is a British Ghanaian doctor by background. He holds Masters and PhD degrees from the London School of Hygiene and Tropical Medicine, where he won the Cicely Williams Prize for his research back in 2013. He's worked for several years now with the Ghanaian Health Service and the University of Ghana Medical School, and continues his affiliation with the London School of Tropical Medicine and Hygiene with regard to public health work. He also has collaborations with the Liverpool School as well, an institution close to my own heart, and the World Health Organization in Geneva. He's conducted research projects in over 20 countries all over the world, and he's a consultant for UNICEF, for WHO, and for the UNFPA, leading various intervention and evaluation projects in maternal and early child health. Alex has currently been involved with the UN Countdown to 2030 Child Survival Equity Technical Working Group and various other international bodies. He tells us he's a perpetual optimist who believes that we can always do more if we believe together, and has the tagline to his emails, as long as there's breath, there's hope. So I hope I've done you justice there. Alex, if you'd like to lead on to your talk, that would be fantastic.
Thank you very much, Stephen. And it's really an opportunity to meet all of you and to talk to you. I hope you're seeing my slides. So I want to talk about how social determinants affect child health and what has COVID taught us in a year that we have been with it. And so I would be quite informal, but we discuss some of the things, because I believe that the child survival since the year 2003, we have been concerned about the survival of the child, especially in low and middle income countries. Over the time from 1990 to 2018, we have reduced mortality from the 12.6 million we had then to about 5.4 million as of 2018. And these have been largely attributed to increased vaccine coverage, better management of diarrhea and pneumonia. But if we look deeper at the numbers and forget about the averages, we would see that there are still inequities around the world. So 99% of the deaths of children around the world are still occurring in low and middle income countries. 80% in Sub-Saharan Africa and South Asia, who are bearing a disproportionate burden of these deaths. And 5 countries in the world, Nigeria, India, Pakistan, DRC, Ethiopia, and if you add China to it, are bearing half of the global child deaths. And the causes of these deaths are known, and we've known them for a long time. So it's interesting, while this agenda remains unfinished. And sometimes I still think that it is looking deeper at where the inequities exist, because even if you look at the child in general, you miss out an important part of these deaths, because a substantial proportion of the deaths are taking place in the neonatal period. And so as far back as 1990, 36% of the deaths that occur in children under 5 were in the neonatal period. By 2016, it has increased to about 47%. So currently, about half of all deaths taking place in children under 5 is in the neonatal period. And it's because the neonatal care is not making improvement. And needless to talk about the distribution of these deaths, because still it is in the low and middle income countries. And it is not just survival, but even development. If you look at that I have and looking at the opportunities children have to grow and develop, you can clearly see that there is a vast difference between the picture on the left-hand side and the picture on the right-hand side. And if you look at the numbers, the picture on the right-hand side is the majority of cases we have in the world. And so it's weighing the scale down. But look at the opportunities they have at that stage in life. So in a way, we are already set up for a systematic difference between children by the place where they are born. And this is something that we need to start thinking about critically. But the problem of the child is because sometimes in most places in the world, they see the child as a small adult. But the child is not a small adult, but a multifaceted issue related from the family level all the way to them come at the disadvantage of the child. So if you are in the home, the newborn is a helpless baby, not knowing what to do. The mothers are clueless, they don't know what to do. The fathers are useless. Excuse me to some of us on this platform who are not in this category, but in many places where most of these deaths takes place, men don't even know how to hold a baby. And then the mother-in-laws are ruthless. They are on the mothers asking them to do things which sometimes are against the health of these babies. The communities cannot do anything, completely toothless. And the health system and the health workers are completely aimless because what they want to target is not what is killing the babies. And we know what is causing these preventable deaths. So I really like this graphic that I picked from Anthony Costello some years ago. And so one would ask that with all these differences we see, are social determinants important? When we talk about social determinants, we're talking about education, rural or urban residents. We're talking about the poor and the rich. And then we are looking at things that really have to do with factors that affect health but are not directly related to health. So within countries, we know that children born in rural areas die more than those that were born in urban areas. In the same way, the poorest mothers lose their babies than the richest, even within the same setting, and the educated more than the illiterate. So these basic things are always providing differences within a population. So if you look at the graphic on the right-hand side, you would see that in a place like Kyrgyzstan, where inequalities are very, very little, you would see that the richest in the population and the poorest in the population are within the same range. And this is looking at the co-coverage indicator, which is an indicator that brings together antenatal, childbirth, and postnatal care interventions and uses it to calculate a composite index for child health and access to services. And you can see that for Kyrgyzstan, almost all the 5 quintiles, the poorest and the richest 20%, are close together. But if you look at Ethiopia and you look at Chad, you will see that in Ethiopia, the richest are far, far better than the rest of the 80% of the population. And in the same way, in Chad, you will see that the richest 20% of the population are way better than the rest of the population. And even in Chad, the poorest 20% are worse off than the middle 60% of the population. So we see these inequalities, and these dictate sometimes how children survive or thrive after the survival. And so I would always say that the averages are always not the true picture. Even in the UK, we know that between counties, we see differences in mortality, we see differences in access to services. And so within health systems, it has been proven that if you take the care or the available resources in a country like Ghana, if the richest people in Ghana, the services they have access to within the Ghana Health Service, if all the population had access to that, without any external intervention, mortalities will be halved. So why do the systems exist, but there is a disproportionate access to the people who are most disadvantaged in society because of who they are? And this has existed from 1971 in the UK when Tudor Hart, the famous proposed the inverse care law and said that care is mostly available to the population that are least in need. And if you have such a situation, the first thing one would think about is, okay, then let's bring the care available to everybody. Bring NHS, bring whatever it takes, health insurance systems or other interventions that is going to improve the lot of everybody. But immediately you introduce that intervention into a naive population, then the inverse equity hypothesis that was proposed by Cesar Victoria and the team in Pelotas, Brazil, comes into play, because it says that anytime you introduce a new intervention into a naive community, the people who are well off are the first to access those interventions. And it is only when they saturate before it trickles down to the poorest in the population. So we always have these things in our minds that if we really want to make an impact in poor settings and address social determinants of health and how they affect child mortality, then we have to be intentional. And an example of an intervention that was done to intentionally target the poorest in a population was the Ghana New Hints trial that I was involved in with Professor Betty Kirkwood in the London School some years ago. And in New Hints, basically what we did was we used community volunteers, and that is the yellow graphic, community volunteers to conduct 5 home visits to mothers, counsel them about care seeking in pregnancy and after the child is born, and supporting them after the child is born to assess newborns. And when they are sick, they refer them to the hospital. We were using these volunteers specifically because we thought that they were available in the communities, they would touch the poorest. And so we needed to have some pro-poor intent in what we were doing. All the other balloons you see around these are things that we in order to enhance sensitizing health workers and providing support for the volunteers to be made acceptable. What did we find in New Hints? At the start of the intervention, if you look at by wealth quintile, the poorest were down here and the richest 20% were up here in terms of access to care. So care seeking, independent care seeking for sick newborns. And if you look at overall, there was no difference at baseline, 53.3% in the comparison facilities against 52.5% in the New Hints intervention facilities. Again, if you look at rural and urban residents, you will see that the urban dwellers were way better than the rural dwellers. But what happened after New Hints? You would see that the graphs have changed. So the blue again remains the comparison facilities, and overall, the comparison facilities remain 5.4 from the 53.3 we had at baseline. But in the New Hints intervention areas, we went up to 75.3. But you see, again, the average doesn't tell the whole story. But if you look by wealth quintile, you'll see that the poorest 20% now have 95% access to care seeking compared to the rest of the population. So it was a complete reversal of what we saw at the baseline. And we were happy about this pro-poor approach to the New Hints and what it has been able to achieve. So basically what New Hints taught us and what the world is telling us is that success is possible even in low income settings. People don't need to be rich before they can do well, as long as we think about addressing these important social determinants of health. And Sunil has given us a lot of examples how African countries, even though have very low COVID infection rates, you can see how the schools have closed down, children who don't have access to services. And I'm going to give you an example about Ghana and what is happening in Ghana as we go along. But this graphic is basically to say that some countries have low income, but they're still doing it well. On the vertical is the neonatal mortality rate, and on the horizontal is the GDP per capita. And you can see that there are some countries that have low GDP, but still are doing very well in this graphic. But keep this graphic in mind and look at what is happening in COVID as we go along. So I took the top 20 most populous countries in Africa, and I'm talking about Nigeria from 207 million population to Mali, which is about 20 million population. And I'm looking at death per infection, per 1,000 infections on the vertical axis, and this is the gross national income per capita in 2018. And you can clearly see that the poorest countries are at the bottom here, and they have the highest rates. And then as you get richer, you see that the graph comes down. But even this does not tell the whole picture. And I tried to look at this in context with some of the richest countries. And my most loving country, UK, is up here. And you can see where we are in the scheme of things. US has the highest numbers, but if you still look at it, their deaths per infection is not as high as what we have in the UK. And if you have the world average here, you can see that the US and France and Spain and Germany are around the world average. It's only we in the UK who've gone high above the world average and performing as poor as Tanzania is doing in the scheme of things. But as I said, this does not tell the whole story. If you look at this graphic for the African setting again, and you look at the countries that I've shaded in red, in fact, including Egypt, you'll see that these countries are still battling with civil conflict. Conflict in Sudan, conflict in Niger, Boko Haram in Mali, Boko Haram in Burkina Faso, and DRC is not a secret. So you can see that these things, these conflicts have affected the health delivery system in the country. And if you don't have a resilient health system and you are affected by such things, immediately it decimates the health system. And so the health system is not able to deliver. And the people who suffer the most under those circumstances are the children and mothers. Now, it sounds like it's an African problem, but as I painted a picture earlier on, you saw that it is almost the same problem that we are having in the West. And Ebola was in Sierra Leone, but by the time we realized it was in hospitals in Ireland and the United States. So we can on. And we see that inequities are driving some of these things. But if you look at the bottom here, Ghana and La Côte d'Ivoire seem to be doing well. Ghana has about 47,000 cases. La Côte d'Ivoire has 20,000 cases. But they have, even though they are not the richest countries in the region, they have some of the lowest deaths per infection, per 1,000 infections. And so I took Ghana as a case to just look at what is happening so far. Ghana has 49,302 cases with 320 deaths. So this is averaging about 0.6% death per infection. But the first case was recorded in Ghana on the 12th of March this year. And then after that, the country went into a 3-week lockdown, and it started on the 30th of March with just about 48 hours notice. And the rationale the president gave for locking down the country was how to economy back to life. We do not know. What we do not know is how to bring people back to life. So he has this intention of life against anything else. So the lockdown came, and then we realized that no, livelihoods is not just about life, but livelihoods were also dictating so many things. So they needed to distribute food for people in the informal sector, and there was so much chaos around it that we thought, come on, this is rather going to fuel the dissemination or the transmission of the virus rather than safeguard the country. So then they opened up again. But somehow they resorted to what they call the 3 T's: test, trace, and track. So if you found the case, track the case, test the case, and continue the contact tracing. Somehow the mortality level is at 0% per infection. But we can see that over the last couple of weeks, the cases have started going up again, consistent with the global trends that we are seeing, because Ghana has one of the highest traffic for airlines into the sub-region. And so we are importing cases and we are transmitting in the communities because somehow complacency set in. So we are thinking, should we lock down again? But all these things do not tell everything, because you might even think about the COVID alone, but the effect on children will become real. And in the next couple of weeks, we are looking at modeling how these things are affecting child deaths in the country and maternal deaths in the country. And even on the surface, when we took some data about immunization in Ghana, and we number of children immunized last year, 2019, in the first half of the year, against the number of children immunized in the first half of this year, we can see, and not even adjusting for increase in the number of children due to the higher number of birth rates compared to death rates, you can see that even using the last year numbers as the base, there have been some 3% to 7% fall in vaccine coverage rates compared to last year. And these are going to directly translate into infections, into deaths, and into many, many challenges that a child would have. So I would say that COVID has taught us a lot, but there is so much more that we can do for the child. And the social determinants in our communities, whether in Ghana or in the UK or everywhere in the world, whether at the global level or at the local, national level, all these things become significant when it comes to health. And mothers and children are the ones who suffer the brunt of most of these. So the child is looking up to us, and I believe that as professionals in the UK, we have the mandate not only to look within, but to reach out to the globalized world. And I was happy about the experiences that have been shared both by Sunil and other colleagues who have been to the Gambia. And this is really important because we have gotten to the point where we have to understand that child health is not just about sitting down and looking on, but for them to survive, the time to act is now. And so the child is looking up to us. Thank you very much.
Thank you very much, Alex. That was a fantastic talk and really interesting to hear how things are in Ghana. Got a very good question from Sunil. He was wondering, have you got any comments or examples of good examples of policies which have favoured poorer families in this pandemic? And then interestingly, how can nations and professionals make these policies appealing to decision makers?
Okay. Yes, so this is a really, really complicated question. And I think that COVID has become not only a health challenge, but it's also become a livelihood challenge. And the third component of it for countries like Ghana and probably the United States is a political challenge. And so there is this delicate balance between politics, health, and livelihoods. And in one way, even if a government is, for example, in Ghana, when the food distribution came in because they realized that there were so many people in the informal sector who thrive on a daily, what they earn in a day, basically hand to mouth sort of thing. And because their livelihoods have been closed down by the lockdown, they needed to be supported with feeding. Then it became a political issue. So the opposition party says that, it's a populist approach and it's going to affect the country and the country is in debt and other things. So it's really, really complicated. What I really liked about some of the things that have been done in Ghana is the fact that they pushed through to allow students in the final years to write their final examination and to make progress. The other thing that they also did was that they thought that in order to provide social distancing to students in the schools have been divided. And so for the secondary schools, after the final year exam, then they also went in to do a semester and came back home. Then another group goes in to do a semester and go home. So the students have not been left completely out. However, there are still livelihood challenges. People are initially started people struggling even to have hand sanitizers, people struggling to have face masks and other things. But we've gone beyond that and we have had people losing their jobs and other things. So if you ask, where should government target? I think the easiest ones that people can think about are the simple things that would ease the lives of the ordinary person. And in Ghana, electricity has been made free because they thought people are going to be staying home. They will be using electricity more than they have been doing before. So it's been made free till the end of the year. Water supply has been made free because if you're asking people to wash their hands and they don't have water supply, then that's a problem. So that has also been. So I think basic things have come to support the ordinary Ghanaian. Electricity, water, they've also asked homeowners to relax their mortgage, their rent to their tenants in order to support them through these difficult times. There are some of the things that the government had no control over. But some of these basic things that touch on the livelihoods of the ordinary Ghanaian, I think have come to help a long way. So if you ask me, what would be the catch? I would say that access to health would be critical. Because even when we started talking about this vaccine, and Sunil was talking about the vaccine hesitancy, Ghana is one of the countries that would have a strong challenge putting this vaccine out unless clear education is out there. And in a political year like 2020 for us, it's really complicated. So I feel that education is the right one, the health is the right one. And these social interventions like electricity, fruits that we can hang on to, but there would be more than that if we need to go forward.
Thanks very much, Alex. One very quick question. You answered a little bit there. Yincent makes a point that actually your vaccine rates during COVID, he thought were pretty good actually to stay above 90% during a pandemic. So I just thought perhaps a quick answer, just thinking about the COVID-19 vaccine. What are your thoughts on access to any potential vaccine in Ghana, and particularly those in poorer socioeconomic classes?
Okay, thanks. I think for Ghana, the issue is that all vaccines have been free so far. The only time that we had to pay for vaccines was when Hep B came initially. And then now it's been added to the routine vaccination system in the country. So vaccines have been free. The access would be beliefs and myths around the vaccines and people not understanding fully what the vaccine is going to do. And people already have their perceptions around what the vaccine are potentially doing and so many things around it. So I think that is one of the things that I fear in terms of the uptake of the vaccine. But we already have projected that if a vaccine is going to come to Ghana, probably consistent with the inverse equity hypothesis, UK and US and the developed world would probably start saturating before they trickle down to us in Ghana. So we have gone back to the basics and they are saying, wear your mask, hand sanitize. So I have my mask sitting with me as I sit here. Wear your mask, hand sanitize, because we are nowhere near the vaccine here in this country. And even before the vaccine gets out there, we need a bit of education for everybody to what the vaccine potentially holds for everybody, because the myths have already permeated the system. The beliefs about 5G, the beliefs about Antichrist, the beliefs about, and we are a religious country. So anything that you tailor towards religion becomes very, very touching to the Ghanaian. And they have added all these things about Antichrist and other things. So I think we have some distance away from the vaccine in Ghana.
Thanks so much, Alex. I think that's time for questions over now. I'm sure people can contact you for further questions. So I'll hand back over to Stephen for the next talk.
Yeah.
Thanks so much, Alex.
Thanks again, Alex. That was fantastic. Thank you very much indeed.